Hello friends, I am Dr. Farheen and let's do a rapid revision of antepartum hemorrhage. Here we will discuss adherent placenta. Alright. So let's go through the basic physiology first. We know that the placenta has two parts, fetal, which is the chorionic plate, and the maternal, which is the decidua. Now this decidua is further divided into compacta, then outer layer will be spongiosa, and the outermost layer, the third layer, is the basal layer. Alright. Between the compacta and the spongy layer, okay, so this is the spongy layer and this is the compacta. Between this layer lies the knitterbush layer of fibrinoid degeneration. So this is this layer which inhibits the placenta from further migrating into the myometrium. So this is the limiting layer. Okay. So the limiting layer is knitterbush layer of fibrinoid degeneration, and at the time after delivery the placenta separates. Okay, placenta separates from which layer? From the spongy layer, which is lying beyond the knitterbush layer of fibrinoid degeneration. Hope I am clear. Okay. So what are the causes which can lead to an adherent placenta? Like the placenta is not able to separate. So either there is total absence of the decidua basalis, there is imperfect development of the knitterbush layer, right? Or the physiological line of cleavage only is absent. Okay. So adherent placenta can be of three types. Accreta, which means adheres. It is seen in 85% of cases. Increta, invades. So here the placenta is invading up till the myometrium. Alright, it is still within the uterus but it has gone up to the myometrium, as we can see over here. And percreta is penetrates. Right, 5%. We can see that it is going beyond the layer of the uterus. So behind it can go into the bowel, and in the front it can go into the bladder. What are the risk factors? The most common risk factor that we need to remember is any previous scar on the uterus. It can be a prior cesarean section, a previous myomectomy, or a previous DNC. Plus, if the patient has an anterior placenta or an associated placenta previa, then the risk of suspicion is very, very high. Okay. So how does the adherent placenta look on ultrasound? So first let's discuss the normal one. This is the normal placenta. But it's a placenta previa, right? This is placenta previa. Why is it so? Because this is the fetal head and all of the placenta is lying over here, right? This is the bladder. This black part which is filled with urine is your bladder. Now we can see a retroplacental hypoechoic zone over here, right? Can you see this black line? So this is the retroplacental hypoechoic zone. In this picture, this shows an adherent placenta. Why? Because all of this is the placenta and it is attached to the bladder serosa. There is no black line, right? So there is no hypoechoic line. Again, it can be appreciated in this picture, the loss of the normal hypoechoic retroplacental zone. So this is a very beautiful picture. Here the placenta is partially adherent. So till here, no black line can be seen between the bladder and the placenta, right? No black line. But here we can appreciate a thin black line, right? So this is a partially adherent placenta. And what is the diameter of the hypolucent zone? So the distance between the bladder wall serosa and the uterine interface should be less than 1 millimeter. Now next feature is a placental vascular lacunae. What do we mean by this? As we can appreciate over here that this is again the bladder, this is the fetal head, and all of this is the placenta, right? And these are the vascular lacunae which are filled with maternal blood. So these placental lacunae or placental lakes, okay, they are also known as placental lakes. They are the pathognomonic feature of adherent placenta. What are the other findings? Now if on ultrasound, if it is not clear, then we go for a Doppler investigation. Doppler is the best investigation to rule out adherent placentae. So what are the findings seen over here? There will be increased intraplacental lacunae, as we have already discussed. There will be hypervascularity at the uterine serosa. So this is the uterus, okay, this is the uterine serosa and this is the bladder. So we can see increased hypervascularity at the bladder and the placental interface. placenta can be seen also bulging into the bladder, right? Now, MRI is recommended only if the ultrasound is inconclusive. So if they ask you what is the investigation of choice will always be ultrasound Doppler. But if they ask you what is the best investigation to rule out adherent placentae, then it will be MRI. Alright. What is the management? Management is that we go for a cesarean section between 34 to 37 weeks of period of gestation. Thank you. This was all about adherent placentae.